Hi, my name is Saad Usmani. I'm an assistant professor of medicine and director of developmental therapeutics at the Myeloma Institute in Little Rock, Arkansas. I'm here at the ASCO 2013 annual meeting presenting abstract titled Total Therapy 5 Clinical Trial on High-Risk Myeloma in Comparison to Total Therapy 3 A and B. This is a prospective phase 2 clinical trial specifically for newly diagnosed, genomically defined high-risk myeloma patients based on the prior experience with Total Therapy 3 trials in which a dose-intense approach was utilized, giving 2 cycles of induction chemotherapy with VTD-PACE followed by 2 melphalan-based stem cell transplant. Then that was followed by 2 cycles of consolidation with VTD-PACE and 3 years of maintenance with bortezomib and IMiD and dexamethasone. What was observed was that the 15 to 20% high-risk myeloma patients would be relapsing in between those intense chemotherapeutic interventions. As the host was recovering, so was the disease. Based on that observation, the Total Therapy 5 was designed in a dose-dense strategy in which the VTD-PACE backbone was employed in combination with varying doses of melphalan with 2 stem cell supported intervention to give 5 cycles of therapy in order to reduce the treatment related mortality and to see whether one can have more sustained complete remissions for this very difficult to treat high-risk newly diagnosed myeloma patient population. Compared to the Total Therapy 3 experience in which the dose intensity led to a treatment-related mortality of about 10% in this patient population, in the newly diagnosed myeloma patient population that includes both low and high-risk patients. Within the high-risk patient population, the 1-year treatment-related mortality was 0%. The key findings of this particular phase 2 clinical trial in comparison to the Total Therapy 3 high-risk myeloma experience is that the 18-month overall survival was significantly higher at around 96% in the Total Therapy 5 experience compared with roughly 70% in the Total Therapy 3 experience. What we also observed was a higher rate of complete responses where 2/3 of the patients achieved complete response, whereas 10% of the patients achieved stringent CRs with this particular chemotherapeutic schema. What, however, we did observe was that the progression-free survival eventually met up with the Total Therapy 3 experience at 18 months, so that there were no differences in progression-free survival, which the investigators feel was a function of ineffective maintenance therapeutic efficacy. The point being that even if you are able to reach deeper remissions with the initial combination chemotherapy, one is unable to sustain that remission by way of maintenance therapy with the available drugs we have. This leads to the point that we do need more effective anti-myeloma drugs for that high-risk patient population. There will always be subclones within a given myeloma patients of myeloma cells that are proteasome resistant and higher, they have a higher genomic chaos, and based on the proportion of those cells, the high risk conferred by that genomic chaos will have a role to play in therapeutic efficacy of the available agents. So the point being, high-risk myeloma is still a major issue, and we do not have enough drugs for it. And even with the Arkansas approach of combining all effective anti-myeloma drugs, even with a dose-dense or a dose-intense strategy, does not alleviate or mitigate that high-risk group.